Rural India is an important part of India. Nevertheless, the face of rural India portrays a living below the poverty level with a high disease burden, low level of awareness, and chronic poverty. Little beyond the Kapilas foothills in Dhenkanal district, these are a cluster of villages with predominant SC and ST population. Their deprivation and vulnerability to malaria and TB make them ill more easily. Illness makes them even poorer. It further leads to a low maternal and child health with the gender disparities that pervade all aspects of their life. Same is the story in the Jajpur district. The sick people around would have resorted to the PHC at Khankira and Atta, but those had no adequate infrastructure, staff, equipment, or medicine to fall back upon. Left with one option, they would knock the door of village quacks, allowing themselves to the realm of financial as well as health burden. With the same in view, Nishadri undertook a project called Community Empowerment and Advocacy for Sustainable Healthcare for People in Extreme Need in Orissa, CIS, with the partnership support of the European Commission and Interact Worldwide, UK. The project is designed to strengthen the public health in Orissa through policy reform and empowering the community at grassroots. The crux of this initiative is partnership. Having executed a needs assessment, adequate groundwork at the community level, and a strategic behavior change intervention, Nisadri augmented a communication practice which included sensitization at the state level and at the below state level of the key government functionaries and development sector players in the state. This process not only opened dialogue with the government to PPP formation, but also augmented the signing of MOU with the government of Orissa for management of two PHCs, one at Atta in Jajpur and other at Khankira in Dhenkanal district. Redefining roles and responsibilities, building capacities, instituting objective as well as transparent monitoring and evaluation systems, holding health personnel accountable for specific outputs and outcomes was imperative. It required a great deal of imagination, innovation, and initiative to forge meaningful partnership and develop institutional mechanism for harnessing the dynamism and enterprise for the private sector for accomplishment of national health goals. Nisadri renovated the PHC buildings and established basic facilities such as electricity and telephone connectivity. It also added basic health equipments to deliver quality health services. It appointed a doctor, an attendant, a pharmacist, and a sweeper at each PHC. All these staffs are remunerated by the organization and managed under the Hospital Management Committee. Capacity building to improve both management and clinical efficiency was considered essential to reap the benefits of decentralization. To make the management more participatory, the hospital management was being undertaken by a body that comprises women, government, and NGO representatives, as well as both formal and informal leaderships of the village. This is in the line of Rogi Kalyan Samiti that is formed as a part of National Rural Health Mission.
ଆମର ଏଇ ଅତା ପ୍ରାଥମିକ ସ୍ୱାସ୍ଥ୍ୟ କେନ୍ଦ୍ର ତଥା ନିଶାଦ୍ରି ଗୋଟିଏ ଜନକଲ୍ୟାଣ ଅନୁଷ୍ଠାନ ମାଧ୍ୟମରେ ଆମର ଜିଲ୍ଲାସ୍ତରୀୟ ସ୍ୱାସ୍ଥ୍ୟକର୍ମୀ ଏହି ଅନୁଷ୍ଠାନ ସ୍ୱାସ୍ଥ୍ୟକର୍ମୀ ଦ୍ୱାରା ପ୍ରତ୍ୟେକ ମାସରେ ଆମର ଏହି ଅଞ୍ଚଳର ଲୋକପ୍ରତିନିଧିମାନଙ୍କୁ ନେଇ ଗୋଟିଏ ଗୋଟିଏ ସେମିନାର ଅନୁଷ୍ଠିତ ହେଉଛି आमे सेतिरे अनेक ज्ञान आहरण करछु एवं सेही ज्ञान को लोकमानक निकटरे आमे पहुँचाइबा पई सक्षम होई पारछु।
Poverty has a direct influence on food security of the rural poor, and women in particular suffer the most during such scarcities and calamities. Thus, ensuring food security through promotion of micro enterprises and various income generation activities for sustainable rural livelihood became an important aspect of women empowerment. Empowerment of women involves many things: economic opportunity, social equality, and better access to healthcare services. Empowering women is the best chance that the global community has to meet some of the prime United Nations Millennium Goals, such as the eradication of extreme poverty and hunger, universal primary education, gender equality, the reduction of child mortality, the improvement of maternal health, and the end of HIV/AIDS, malaria, and other diseases. Under the SEAS program, different communication tools as well as methods were used for health education. For the purpose, different committees such as Emergency Obstetric Care Clubs, EOCC, health committees, and the Kishori clubs have been formed by Nishadri in the area to sensitize the community members on specific health topics. Government health education programs are also leveraged to achieve this objective.
यदि ए परिष्कार परिच्छन्नता न रहिबा मेन समय रे यदि मासिक ऋतुस्राव जो होचे से समय रे कन करबा हमें परिष्कार परिच्छन्नता न रहिले विभिन्न प्रकार इन्फेक्शन हुए।
ऋतुस्राव समय रे परिष्कार सुखिला कपड़ा व्यवहार करंतु। प्रसूति महिला माने निजर जननी को परिष्कार परिच्छन्न रखिया पे आपण माने बुझांतु एवं ऋतुस्राव बेले प्रतिदिन पैड और कपड़ा दुई थर बदलांतु। स्तन सफा करी भल भाव परिष्कार रखंतु एवं ऋतुस्राव समय भल भाव गाधोई परिष्कार परिच्छन्न रुहंतु।
In order to provide the health services at the doorsteps of the villages, the PHC organize outreach regular health camps in the catchment areas. Besides providing the basic health services, the outreach team takes up health education activities. They create awareness on different health issues such as malaria, mother and child health, immunization, nutrition, HIV/AIDS, polio, tuberculosis, cataract, eye care, and the like. While the PRA involvement is one strand of decentralized health governance and implementation under NRHM, the other strand is the community involvement in the health governance. It is evident that such devolution encourages local bodies to consider health as integral to development activities. As such program dovetail intersectoral linkages of drinking water and sanitation, nutrition and environment. Infrastructure, incentive and initiatives have enabled and ensured the availability of the PHC staffs for emergency services. 24/7 accessibility to health services of these PHCs have not only strengthened people's confidence on the PHC, but also resulted in improved health service seeking attitude among the target population.
दीदी शीशा जगटा कम बिंधुची बथा बेला लगुच तलीपटा कम फुटुची मो सर दीदी कहते कपड़ाटे साबुन मारे सब सफा रखा तलीपटा साबुन मारे देह हाथ साबुन मारे सब देह हाथ सुस्थ रहा।
The strategy is successful in synergizing the core competencies of both the government and Nishadri to plug the gaps in the management of the PHCs and make them functional and viable. While the government legitimizes the strategy, Nishadri brings in its expertise, commitment, and understanding. The concerted advocacy effort in the line of behavior change communication has been instrumental to revitalize rural health in these two pockets. The demand for health service has been increased in manifold, which is evident from the consistency in increased inpatient inflow to both the PHCs. The social marketing program is integrated with other development activities of the organization in the area. The success of this program is viewed as for effective decentralization, flexibility in decision making, timely release of funds, and adequate accountability systems.
मो जेडपी मेंबर आरकेएसर जड़े मेंबर हिसाब से जेकोसी उन्नयन कार्य होची स्वास्थ्य विषय रे काली आमर जो रोगी पहुँची डेलीवरी पाई एवं आम एठू 20 किलोमीटर मेडिकल सुकिंदा पीएस जापर नहती तेणु आम ए जगार चिकित्सा भाव में आम निशादी तरफ आम एठी करूँ विभिन्न उन्नयन कार्य जिते समीक्षा आमर सबू मीटिंग रे आपणकर एएनएम अंगनवाड़ी वर्कर आमर निशाद्री और विभिन्न स्कीम जिते अफसर सब ये एकाठी हो विभिन्न प्रकार आलोचना कि भाव में स्वास्थ्य सेवा उन्नति करवा ये अंचल को कि भाव में स्वास्थ्य सेवा लोक दे पारिबा से आम सचेतन.
The horizontal transmission of knowledge through interactions, practice, and close involvement in the community and proper training of health workers in villages has helped in reducing maternal and infant mortality and teaching preventive aspects of health.
पब्लिक प्राइवेट पार्टनरशिप द्वारा ये जो ग्राम लोक मान जो मनकर हेल्थ कैंप कर चिकित्सा दान करवा ये गोटे जिनस द्वितीय हूँ जो औषध पत्र सुविधा करवा ये गोटे जिनस तृतीय कथा हूँ जो मनकर हठात कि सीरीयस किए पड़ा तार इन्वेस्टिगेशन जो सुविधा नाला ताकू करवा ये गुड़िक ग्राम पाई पार नी ये गोटे जिनस यही प्रकार भाव में ये पीपी सफलता ग्राम मुखर करुच्छी.
Experimented in 2 PHCs, the model has impact on the entire rural healthcare system of the state. Public-private partnership (PPP) has emerged as one of the important strategies for health sector reforms in Orissa.
This PPP has really become a success, and the success can be seen in terms of the availability of the modern and new equipment instruments at the hospital. The success can be seen in the form of the increase of institutional delivery that has happened after the involvement of the NGO Nisadri here that were earlier not there, and the success of the PPP can also be seen in the increased number of OPD patients that has about doubled after the initiation of the PPP. So we can say that this model of PPP can be emulated, can be followed by other PSNUs of the state.
Akin to the goals of efficiency, equity, quality, and accountability, the PPP program in these areas are studies of good practices in revitalizing rural health.
The program is an innovative program in a very remote area like Kankira, and it has shown good achievement during the starting period from inception till today.
SEAS project has enhanced the capacity of rural community groups, PRI members, and the civil society at large in health-seeking behavior through improved health services and awareness on general health and sexual reproductive health.
And after involvement of private partners in the government program, we have seen that we have been able to bring about a lot of improvement in our health infrastructure in the field. The patient services have improved in a major way. The footfall in the peripheral institutions has also increased, and thereby the referrals to the general district headquarter hospitals have decreased. And moreover, since these local partners have been working with the people in a very closely associated way, they are able to better gauge the problem of the people and instantaneously deliver services as per the needs of the people.
Reduction in infant mortality and maternal mortality rate, increase in antenatal checkups, delay in age at marriage for women, increase in per capita income, women's participation in decision making, and control over resources are the perceived changes.
आमर खंकीरारे मेडिकल हो गला आगे थिला गवर्नमेंट मेडिकल से मेडिकल रे कई डॉक्टर रहू नथिले सेडू ए जो संस्था आमर निशादेरी मेडिकलटा नहीं गले से मेडिकल रे डॉक्टर गुटे रखिले से मेडिकल रे हमको एना जेतेबेले राती ओदारे आम मेडिकल रे जाईगिरी भल होउछ
हमर डिलीवरी केसटा माने घरे क्लास न करिगिरी नेकी जाउछु कंकरिया डाक्टर कनेगु जो कंकरिया डाक्टर माने एबे आसिकी रहलेन जे सेटिकी आमे नेकी जाउछु सुविधा हेलानी
जर हेले भी औषध पत्र मिलुची कि जा केस पेस पड़िले भी से निशादेरी तरफरु गाड़ी मोटर भी पटई दउची राति उदारे फोन कला बड़को गाड़ी मोटर भी पटई दउची आमे राति उदारे भी मेडिकल के नेकी जाउची.
However, reorientation of staffs at PSCs on different health programs, regular monitoring by block and district level authorities, transparent financing together shall usher in a smooth and appreciable delivery of health services in remote areas. The partnership has facilitated a process of establishment of an equalitarian and healthy society with equal access and control over the resources. Now the communities have acquired the opportunities to knowledge, information, resources and participation in decision-making process. This initiative will create ripples in health sector interventions